This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara. Today, we're looking at a fascinating new study from the Journal of Neurology, Neurosurgery, and Psychiatry, published in 2026. The paper is titled Time to Surgery and Postoperative Functional Outcomes Among Patients with Chronic Subdural Hematomas.
This is a topic that hits home for anyone on the call schedule. Chronic subdural hematoma, or cSDH, is one of the most common conditions we treat. It's often seen as a bread-and-butter procedure, but as this study highlights, the management of these patients is far from simple.
Exactly, Dr. Aris. While we know that surgery remains the preferred treatment for symptomatic patients, there has always been a lack of consensus on the golden window for intervention. Unlike acute subdurals, where every minute counts, cSDH often sits in a gray area. This study specifically investigated the relationship between the time to surgery, what we call TTS, and the postoperative functional outcomes.
It's an important distinction. In a busy neurosurgical unit, delays are often inevitable. Dr. Alara, the authors mentioned a few specific reasons why these delays occur. What were the main drivers?
The paper categorizes delays into three main buckets: logistical, clinical, and medication-related factors. Logistical factors might be theater availability or transfer times. Clinical factors involve the patient's own stability, but the medication-related factors are perhaps the most common, specifically the need to reverse anticoagulants or antiplatelet agents before we can safely pick up a drill.
That's the constant tug-of-war we face. We want to operate to relieve the pressure, but we don't want to cause a fresh hemorrhage because the INR is still 3.0. According to the paper, what were they trying to solve by looking at the TTS?
They wanted to see if these delays actually translate to worse functional outcomes for the patients. We often assume that because it's chronic, we have all the time in the world, but the study suggests that the brain might not be as forgiving of prolonged compression as we once thought. They looked at how long it took from the moment of diagnosis or admission to the actual skin incision.
Right. And for our listeners, especially the residents, functional outcome is usually measured by the modified Rankin scale or similar metrics. If a patient comes in with a headache and mild hemiparesis, our goal isn't just to empty the collection, it's to return them to their baseline. What did the study find regarding that relationship?
The data indicates that time is indeed a factor. While cSDH doesn't always require the emergency status of an extradural hematoma, prolonged time to surgery was associated with a measurable impact on how well these patients recovered their function. The symptomatic part of the diagnosis is key here. If the patient is symptomatic, the brain is already struggling to compensate.
That's a crucial point. If the brain is already under strain, every extra day of compression from that hematoma and its associated inflammatory membrane could be causing secondary injury. You mentioned medication-related delays. Did the paper offer a perspective on balancing the risk of a delay against the risk of operating on a patient who isn't medically optimized?
The authors emphasize that while clinical and medication-related factors are sometimes unavoidable, we need to be mindful of the logistical delays. If a patient is medically ready for surgery, any further delay due to theater scheduling or staffing could be detrimental to their long-term functional recovery.
It really challenges the "we can do it tomorrow" mentality. If the evidence shows that functional outcomes are tied to TTS, then cSDH needs to be prioritized higher on our lists than it traditionally has been. We often talk about time is brain in stroke or trauma, but this paper suggests time is brain applies to chronic subdural hematomas as well.
Precisely. The study serves as a call to action for hospitals to streamline their pathways for cSDH. It's about recognizing that chronic refers to the age of the blood, not necessarily the urgency of the patient's neurological needs.
A very well-put distinction, Alara. For the residents listening, when you see a symptomatic cSDH in the ER tonight, don't just think about the burr holes. Think about the clock. How can we get this patient optimized and into the OR as efficiently as possible?
It's a great reminder that our logistical decisions in the hospital have real-world consequences on whether a patient walks out of the hospital or requires long-term care.
Well, that's all the time we have for today. An excellent look at an important study.
Thank you, Dr. Aris. We'll see you next time on the Neurosurgery Hub podcast.
Goodbye.